When we work with chronic pain in EMDR, one of the elements that often confuses clinicians is the antidote. Where does it go? Before processing? After processing? Or both? And why does it differ from the standard EMDR protocol? So let's break it down in a really simple clinical way. The antidote is essentially a corrective experience. It's the nervous system's alternative to pain, the "what would my body like instead?" It may be a sensation like warmth or openness, a sense of ease or strength, or a belief such as "my body can heal." It creates a new prediction inside the nervous system that contradicts the pain prediction. Why does the antidote exist in pain protocols but not in standard EMDR? In standard EMDR, we resolve unprocessed traumatic memories. But in pain work, the disturbance is not always trauma. The disturbance is the pain itself. Pain is a complex multi-channel network of sensation, emotion, belief, and learned bodily responses. So we need a corrective template, something that helps the nervous system reorganize around safety rather than danger. Where the antidote is placed depends on the model you are using. There are actually two legitimate placements for the antidote, depending on the protocol you follow. Some protocols place the antidote before processing. In these versions, we identify the antidote right after identifying the pain target. So we might ask, what would your body like instead? Or what would contradict this pain? We install the felt sense of the antidote before we begin bilateral stimulation. The purpose here is regulation. Pain often comes with hyperarousal and sensitization. By adding the antidote early, we reduce activation and provide the nervous system with a safe alternative template from the outset. Other protocols place the antidote after processing. In these models, we process the pain experience first. Once the pain shifts, even slightly, we then introduce the antidote as a new way of being. It becomes a kind of future template or functional template. This helps the body integrate the new pattern and prevents the system from falling back into old pain predictions. Both approaches are correct. They simply serve different functions. The antidote before approach helps regulate, titrate, and keep the system safe. The antidote after approach helps consolidate, integrate, and reinforce neural change. So, in practice, we can think of the antidote as flexible. It can be used for stabilization or for consolidation, depending on the client, their level of sensitization, and the approach you were trained in. A simple way to teach it to yourself and clients would be that before processing, the antidote helps the system feel safe enough to do the work. And after processing, the antidote helps the system learn a new way to be. When in doubt, remember this core principle. Pain is fundamentally a prediction of danger. The antidote introduces a competing prediction of safety. Where we place it simply depends on whether the client needs safety first or safety reinforced at the end.